So welcome to the Eastside Freedom Library. There are restrooms downstairs. We also just yesterday opened an exhibit from the Minnesota Humanities Center called Why Treaties Matter, and that exhibit is downstairs later on this evening. You'd like to take a look at it. So what we're doing is we're having a monthly series here that we're calling the Labor Movement and, as a way of exploring ways to extend the traditional boundaries of the labor movement. And so we've addressed issues like the labor movement in Me Too, the labor movement in Black Lives Matter, the labor movement and the fight for 15. Okay.
Oh no, they're right there. Thank
Good.
God.
And next month we will be doing the labor movement and the fight for immigrant rights. So please make sure you sign the guest book so that we will send you our monthly electronic newsletter and you'll know exactly when things are happening and what's going on here. We're delighted that these great folks could be with us tonight to talk about the fight for healthcare reform, and that we can explore the role of the labor movement in the fight for healthcare reform. And our panelists tonight are Lisa Weed from SEIU Healthcare, Aarti Bahtt.
Yes.
Aarti Bahtt from the Public Health School at the U, or?
I work at the Community University Healthcare Center.
Oh, great, great. And you're an MD?
I am.
Yeah. And Amy Finnegan, who's the chairperson of Peace and Justice Studies at the University of St. Thomas and involved with the group SocMed. And then we have Roach from the Minnesota Nurses Association. And we had gotten word just before we were going to start tonight that Senator Marty is stuck on the floor fighting around a bill, and we are expecting him to join us. So we hope that there will be a lively conversation tonight after the presentations. I also want to call attention to Ann Jones. Ann, do you want to explain what you're doing back there?
Well, if you hear anything tonight that makes you want to take some action, we're here to help you with, if you give us your contact, if we're organizing and educating the public about healthcare payment reform and ready to take this movement forward. So join us.
Great. And Ann is an RN, right?
Yes.
Yeah.
And my friend Dana is our awesome and a veteran.
And a veteran. Great. All right. So I'm going to play the important role of pushing the advance arrow for roses. And I don't think we need the sound.
Good Lord.
I'm
a union organizer.
Yeah. Okay. Excellent.
Right. I'll go here though so you can see the slide. Well, first of all, good evening, everybody. Again, I'm Roach, the Executive Director of Minnesota Nurses Association. I am not a nurse, so I always make that disclaimer up front. I am a trade unionist, been in the labor movement for over 30 years, and realized about 20 some years ago that the issue of healthcare is really a failed strategy for us to think that we can negotiate that beast anymore at the bargaining table. And so began to learn more about health policy, what drives healthcare costs, and what should we be doing to actually recognize healthcare for the human necessity and the human need that it is. So I usually start these out by saying, good evening, fellow patients. Because we are all, if we're not in that role, we will be someday, right? Yeah. So you can go ahead, Peter. So I want to start with a little brief history, because that's what Peter asked me to do, about the role of labor and healthcare reform, right? So, So way back in 1915, so over 100 years ago, the American Association for Labor Legislation actually submitted a model for a plan for national health care, although they did it, they actually did it through the states. They were trying to work through the state legislatures. And World War I then happens. So this gets pushed off to the side, which happens many times. The AMA, the American Medical Association, originally supported the idea of moving to some kind of a national health care program, but then after the World War I, they flipped and said, no, we don't want to go down that path, and they actually ended up fighting against it. And that caused then by the 1920s, the New York State Legislature Assembly was the first one to get out on this and killed it, basically.
Who was it?
New York?
Yeah. No,
Oh.
who decided that, no, we don't want to go after?
Oh, the American Medical Association, the AMA.
Yeah.
They did,
Okay.
yes, decided that they didn't want to support this type of reform. So next slide, please. So then we get into the 1930s, and you know everyone knows, right? Social Security with FDR comes in following or during the end of the Great Depression. Well, the original bill of Social Security included national health insurance, health care. Okay, but it was, you had insurers now in the picture offering some form of health insurance, and the AMA together, they put together a lobby group that ended up actually killing the bill, or excuse me, removing that from the bill of the Social Security legislation. So, you know, FDR is compromising and he's like, it's a bad time, we just gotta make sure that people have some sort of income so that they can survive, so we'll give up the fight on the health care and we'll live to fight that another day, right? So then in 1943-48, we have the Murray-Wagner Dingell bill. So this was a vehicle that was actually at one point used also for national health insurance, another way in which to tackle it. It was backed by the CIO, so the AFL and the CIO aren't quite together yet, right? So the Congress of Industrial Organizations. They were very enthusiastic about it. The AFL not so much.
Yeah.
They were kind of not so sure about it. They had some philosophical problems with the idea of national health care. The AFL had a tradition of unions being the social insurance providers for their members. And so starting with actually burial benefits in the 19th century. And so by the 1940s, however, the AFL was starting to come around and be more supportive of the idea of a national solution. So then, next slide, Peter. We've got, you know, this idea. So this is, again, these are the kinds of things, and we heard this even in recent history, in our own contemporary history. What are the things they say that are not good about going to some sort of a national health care plan? You get this, you know, oh, it's going to be the government is going to dictate to physicians how to treat us. You know, it's going to be a government bureaucrat between us and our doctor. So this is, you know, almost 100 years old, and we're still hearing the exact same sort of arguments as to why this isn't a good idea. You know, they use this actually, this was the issue in Canada. So I was recently in Canada, and I met with actually one, believe it or not, one of the original architects in Saskatchewan of the Canadian health system. And he said, you know, the physicians were very worried that this was going to be government running and their health care and telling them what to do. They actually went on strike for 12 days, the physicians did, to fight against that. And a lot of it came down to how they were going to be paid in the end, whether it was going to be fee for service, was it going to be capitated rate or salary. And they managed to sit down with Tommy Douglas, if you know that name. He was the premier of Saskatchewan, and that he's the guy who started the whole national health program by getting it up and running in one province first, right? And they finally came to an agreement that it wouldn't be the government that they would negotiate their reimbursement with. It would be this entity that they created between the government and the physicians. Of course, it was a government-appointed body, but it made them feel better. They didn't feel like they were working directly for the government, and they're really kind of not, because there's still many privately owned facilities, you know, up in Canada. Not necessarily hospitals, but certainly there are some clinics and things of that nature, but there's a lot of community clinics too. So this is a very common thing that we see as to how, you know, the fight goes about national health insurance. But the Murray-Wagner bill, also Dingell bill, also had we have the Taft-Hartley Act, right, that follows that then takes a whole different turn. Because now there is more weight put towards employers than there are towards the unions with the Taft-Hartley Act. And this is where we see rollbacks in the gains that labor had made, right, in those preceding years. And we end up with joint labor management Taft-Hartley funds, and they still exist today, mostly in the building trades, where that's how you know, like a carpenter. My husband was he's a retired carpenter. That's how he got his health insurance. You know, you negotiate for a portion of your wage to go into that fund, and then that fund pays for the insurance, right? So then we get another middleman put into it. So the next one, Peter. So in the 40s, we get the defeat of national health insurance. You know, Truman wanted it, tried to put it forward as well. We also, at one point prior to Truman, we had the FDR try for the second Bill of Rights, which included health care as a human right. Collective bargaining starts to happen around health benefits being on the bargaining table, and now that becomes a benefit that is attractive for workers when they are going to go to work for somebody, that they get health insurance, right, through that employer. And then we get into the 60s, and now we have become the only employment-based health insurance system in the world. Okay, that it's all about your job. So next one. So 65, of course, glorious year. Medicare and Medicaid come into being. You know, LBJ signs that into law. I saw something somewhere that said that they can't, you know, he needed to know how much it costs, right? And they gave him a number, and he goes, "Give me a different one," because he was LBJ. So he's like, "I'm getting this done. That one's not going to work for me. So give me the one I need to get this passed, because this is the right thing to do, no matter what." You know, God bless him, right? So we end up with Medicare and Medicaid, and actually, this is at the peak of labor strength in this country, right? We're at like 30% density of all workers in the nation are actually part of the labor movement at this point. But again, not quite strong enough to have this cover everybody. It ends up just simply, you know, covering 65 and over, and also, of course, with the disability and disabled as well. So the next slide, America, you know. So we do it differently. You know, it works, but only for a while, in reality. Again, only employment-based in the world where, you know, Medicare and Medicaid are supplemented by either state programs or by private insurance. If any of you are on Medicare, you know you buy the gap insurance. It's an 80-20 plan, so that becomes problematic. It's beginning to be privatized. Medicare Advantage is nothing more than the privatization of our Medicare system, without a doubt, and it is putting way more costs on that system. You know, we've got England moves after World War II into, you know, true socialized medicine. It's a national health service, right? Canada moves into single payer, and most of the other European countries have some combination of whether it's single payer, whether it is a highly regulated insurance, system that they cannot make a profit on. Their rates are set by the government. You know, it's dictated who gets covered and everything, and how everything gets covered. So one way or another, we're left kind of in an island on our own in the way that we treat healthcare in this country. So next slide. This is the one that is really disturbing, I think, for workers. The very bottom one is the overall inflation. The light blue is workers' earnings, and then you see the darker blue is workers' contributions to premiums and the increase in health insurance premiums. That is unsustainable. The crocodile mouth is not sustainable for us as an economic system, certainly isn't for individual workers and families. It has become, collective bargaining over health benefits has really become a massive transfer of our wealth as workers to the 1%. That's what is actually going on here. It's been a really powerful weapon that is used in the class warfare that we are now engaged in. Next slide, Peter. And on top of that, you may or may not know this, but I thought this was interesting that the Department of Labor estimates that 1 in 7 claims that are made through employer health plans are actually denied. So the idea that just because we are lucky enough to have employer-provided health care means we got the best deal going, not so much, not necessarily. We spend a lot of time arguing with these people about what our doctor said was best for us, which is kind of crazy. So what does that mean? So this one, Peter, is going to be a couple, just click once and then I'll, okay, click. So this is, me and John collaborate on this one. So the problem is healthcare is too expensive. So what's our solution? We make it more difficult to get it, right? So one of the things we do is we limit networks. We tell you who you can see and who you can't see. That's crazy. And then we have co-pays and deductibles. The idea that if we just had a little skin in the game, we would be able to control healthcare costs. All my skin's in the game, it's healthcare. This is nuts, this is ridiculous, and this idea that if we just know the price, I'm telling you, we don't shop for health. I don't decide to have a heart attack because Alina is having a sale on coronary bypass surgery. You know, health is different than everything else that we buy in life, and we've got to quit treating it like a commodity, right? And we have restricting coverage. They're always trying to figure out what is your plan going to pay for and what isn't going to pay for. Remember the debate on the ACA? There were a lot of men in Congress who said, why should maternity care be an essential benefit? I'm never going to get pregnant. Well, they were a fetus at some point, so they should care about maternity care. That's just nuts to say that kind of stuff. And then finally, and the doctor could probably speak to this better than me, but prior authorization. How much time is spent now by our healthcare professionals on this issue of having to get insurance companies to approve their health, what they want to do for treatment. So 40 years of tinkering, we're using less care, we're spending more, and we're getting a lot less and not as good a health outcomes as a lot of other countries are. So the problem really is, you can go to the next one, Peter, just go ahead and flip it. I'll get through this real quick. This is the problem. Here's a big part. How do you like that headline? Goldman Sachs asking biotech research report, is curing patients a sustainable business model? There's your health insurance company profits. And then we got these guys over here who are making $30 million a year, 17 million, 20 million. Doc, you making 20 million a year? Yeah. And so she heals people. They don't. They don't get to get this kind of money, any money, if they're not healing people. That's immoral and inhumane in this system that we have currently. So John's going to talk about the next slide, so I'm not going to go over it too much, but we are in agreement with Senator Marty in regards to what are the principles for a good healthcare system, cover everybody. Let's quit fooling around and saying that dental care and vision and long-term care and mental health are health issues. Treat them separately. Let's get to choose who we want to see for physicians and hospitals. Let's not deny care as a way to control costs. Let's do it by getting rid of administrative waste, base the premiums on pay, on ability to pay, focus on preventative care. Let's make sure that our physicians and our providers are paid well and paid fairly and equitably and in a timely manner, and let's maintain the good work we're doing on healthcare in this state. So again, the next slide just shows you we support the nurses support the Minnesota Health Plan. It's AFL-CIO endorsed now, thanks to those nurses rocking in on the floor of the AFL-CIO convention. You can download the book, that's the website for it. Anne's got some in the back as well. And then we are supporting on a national level the Medicare for All Act of 2019. You can see a variety of unions that were at the press conference speaking in favor of moving towards a Medicare for All bill. It's the most comprehensive ever put forward in the Congress before by Pramila Jayapal, and there's exactly one co-author from the state of Minnesota, and it's Representative Ilhan Omar, and that's it. So we got work to do to get our representatives on. So I know that my time is probably up and I get too chatty on this. So the next slide, just so you know, single payer benefits workers, because it eliminates our need to bargain over something that our employers shouldn't have the right to tell us. Because they're literally telling us what doctors go to because they have to negotiate the plans every year, right? And that's how that limited, networks and everything comes into play. We could how about we start to bargain over wages again instead of putting it all into the pockets of the insurance companies, right? Wage stagnation. How about shoring up our pensions and maybe even going back into, defined benefit pensions for people. And the Minnesota Health Plan offers a much more comprehensive plan than almost anything that we've got out there, even for those of us who have good health insurance. So I'll just wrap it up by saying the cornerstones of our democracy. You can hit the buttons, Peter, again. The first Women's Rights Convention is held in Seneca Falls in 1848, but the Equal Rights Amendment is in 72. Right? 1831, Nate Turner leads a slave revolt in Virginia. It's not till 1964 that the Civil Rights Act is passed. And the late 1940s and 50s, we debate Medicare. We don't get it signed until 65. So the question is, when will this great nation provide health care for all? And that's, the big question mark. Final comment, last slide, you can't cross a chasm in small steps. It is not a thing for us to tinker with. We are literally deciding who lives and who dies and who suffers in pain in this country when we don't fix the system, and we keep thinking we can screw around with it with this goofy insurance system that we have. Time to move on from that.
So, Senator Marty, you want to grab a seat? Lisa, do you want to go next?
Okay.
Okay.
Is it better to stand or can everybody hear me?
Good check.
So I can hear you.
Oh.
Stand so I can.
All right.
All right.
We'll get the union voice out here. Right. Okay, I'm Lisa Weed. I'm an executive vice president at SEIU Healthcare Minnesota. We represent healthcare workers all across the state, about 35,000 of them, from home care to clinics to nursing homes to hospitals. I wanted to start out a little bit about me, my story, because it'll tell you just how much I believe in the labor movement and unions in general. I'm a nurse. I'm from the greater Minnesota area, so I'm not a metro girl. I'm not an urban girl. I like the country, even though I live here. I worked at a nursing home since 1986. Long-term care is my passion. I was a geriatric nurse. I did clinic OBGYN for a little bit, but really love geriatric nursing. And so my heart belongs to nursing home workers. My heart belongs to geriatric people that we care for. So I'm working in this nursing home, and it's a company that isn't in our great state. They're out in Utah, Utah, United States. And they're self-insured. And we have health insurance, and in order for me, I have 3 children. In order for me to afford health insurance, I'm paying $700 a month out of my check. I get paid twice a month. I have a mortgage, right? I'm making $13 and some cents as a nurse. Okay? Nursing assistants are making less than that. I lost my home for medical debt. I was foreclosed on, had filed bankruptcy in my life. I was 30 some years old at the time. My marriage failed. Many social and economic things go with health insurance. And when you're not covered adequately and what you pay out of your pocket, it really destroys you as a person, as a human being, and how you're looked at in society. So, still working at this nursing home. And the boss walks in one day and wants to cut our dietary workers and our housekeepers by $1 an hour. Our nurses and our nursing assistants weren't going to stand for it. We called the union. We organized. People need to organize, right? That's their only chance you're going to get in life, right? Is to organize. Bring people together to make changes. And we won our union. And that's how I came on to be with SEIU Healthcare Minnesota for the last 15 years. And my turf is Greater Minnesota hospitals and nursing homes. Usually in Greater Minnesota, it's a medical center that has a nursing home attached to it. But also in Greater Minnesota is we have a lot of mom and pop nursing homes that aren't owned by these big chains that house across the nation, right? And my concern is the report from the leading agent from DHS. I should get my notes. My story is easy. I'd love to get my notes when I'm using other people's data, right? The Minnesota Board of Aging and the Mapping the Future, Enhancing Long-Term Care for Older Minnesotans. The statistics are unbelievable. So I'm just going to throw a little bit out. Between now and 2030, Minnesota will experience the most dramatic population shift in its history. We will become older as a society, and by 2030, 1.3 million persons, that's 1 out of every 5 Minnesotans, will be 65 or older. That's staggering. Those all baby boomers, right? All baby boomers. And later in 2050, 324,000 Minnesotans will be over age 85. Who's going to care for these people?
Better treat us good.
That's right. That is right. That is right.
We try.
And I would say that greater Minnesota is older than urban Minnesota. And quite frankly, in the southwest, where I'm from, southwest part of the state, and west central portions of the state, 20% of the population is already over 65. Already over 65 years.
20%?
While 30% of the state's total population lives in greater Minnesota, 41% of those are over 65. I wish I had water. A little dry. Thank you. So what are some of the things that seniors are facing out there underneath the healthcare and the system out in greater Minnesota? Our nursing home workers have worked together to kind of compile a list as well as actually talking to the residents that they serve. And some of those are that continuity of care and access. Thank you so much. I apologize. Can you tell I've never done a panel discussion before? So, the continuity of care and access to the range of providers needed is difficult in greater Minnesota. Due to the population declines, consolidations and closures of hospitals to a certain extent, but more so nursing homes. So we just have, a couple years ago, Mayo down in Albert Lea, right? Consolidating their services, taking services for that community and moving them to Austin. 30 miles away, right? What did the community do? They came together, they stood up, they tried to fight the big corporation, right? Unions were there in support, the nurses, SEIU, we were on strike, got locked out over it on Christmas, but we continue. You have to raise your voices in order to make a change, right? So, and these closures have had other effects as well. Longer and more frequent drive times are required to see providers, putting increased pressure on families. Volunteer drivers and public transportation programs. How many public transportation programs are out in greater Minnesota?
Nothing.
Right? How do people get to their appointments? If they cannot depend on each other or their families, how do they make it to their appointments and see providers? And when providers are moving more to the urban areas versus greater Minnesota, where are people getting the care? A significant portion of current long-term care workforce in greater Minnesota is nearing retirement. So even our caregivers, especially in the nursing homes, are getting ready to retire. Where is the workforce going to come from? There are some social and economic factors that contribute to such shortage of workers. And some of those we have heard from our members, and which we see regularly, they're often low paid with no benefits or limited benefits, high workloads, unsafe working conditions, inadequate training, lack of respect from supervisors, lack of control over their jobs. Most nursing home workers just want to sit and have a conversation. want to spend an extra 20 minutes with you per day. And for some reason, they're just not allowed, right? They're working short, higher workloads, not enough staff. You don't have time to sit. When sometimes that is the greatest medicine you can give to anybody, is human compassion. They work an average of about 30 hours per week. The median hourly wage for our nursing home workers in the union for nursing assistants is $14.22 an hour. Compared to other counterparts that aren't union, they're making $12, $11 an hour. Most don't have pensions. Most don't have retirement plans. And if there is a 401k, the employer ain't contributing. Right? And many can't afford the health insurance that is provided by the employer. And you know, the Affordable Care Act was great. It was a starting place. It was something to come into. And at least now the nursing home employers can't work you to death, because if they're paying you 30 hours or more per week in the look-back period, you can get caught, right? That was a great thing that happened. It was a step in the right direction. And I think we just need to keep going further on that to get some health insurance for folks. Direct care work has one of the highest workplace injury rates of any occupation. And I would say that, you know, our state has done some great things. In 2015, the new legislation for the new nursing facility payment system, we revamped all that. Because we used to be a system for reimbursement rates as a deep rural, and metro rates. And we worked together and was at the Capitol, and we got that changed. But what has happened is it added a lot to direct care. But when you're a nursing home worker, you're a team. And residents count on their food, and they count on their rooms to be cleaned and their laundry washed and all of those things. And we've left them under another category called other operating expenses. And they do not see the same reimbursement. The employers are not reimbursed at the same rate. But we think there's some gaming going on by the employers too in their operating costs that they turn into DHS, and how much they're actually paying for health insurance, and how much, you know, they're doing these things. I do also want to touch on, in July of 2018, Kaiser Health News published an article that most nursing homes had fewer nurses and caretaking staff than they had reported to the government, according to the federal data. The data came from the daily payroll records Medicare only recently began gathering and publishing as required by the Affordable Care Act of 2010. That's how long the Affordable Care Act's been around. And they're just realizing this now. Medicare previously have been rating each facility's staffing levels based on the home's own unverified reports, making it possible to game the system. So that was a study that Kaiser had done, and it was in their health publication in July.
You know, provider. They're huge truth tellers, very interesting.
Also in Greater Minnesota, I would say that the changes in families are reducing their ability to provide care for their older relatives. The biggest pressures include, today, there's smaller family sizes, right? People are having smaller families. So there are more number of older relatives to care for than there are for relatives to care for relatives. And the movement of family members into more urban areas, they leave to find better paying jobs. And most of these nursing homes in Greater Minnesota may be the largest employer for that community. And what happens if that place closes or consolidates or goes somewhere else? What happens to that community? Everyone suffers. Everyone needs health care. in this country. And I'm gonna kind of end with, and I probably didn't touch a whole lot, but you know, Rose is pretty right on. It doesn't pay for us to bargain health insurance anymore. It's a joke. What we need to be doing is at the Capitol, moving and talking and telling our personal stories. Even if it's the hardest thing you ever have to do, if you've been affected by a healthcare issue, you need to tell your story. People need to listen. I'm gonna end with, my dad has been gone now for 10 years. And my dad retired and he lived on his Social Security. Had a little Medicare, had a little SocMed, whatever. He had a massive heart attack. Lived through it. Was on numerous medications after that. And he rationed his medication. We were at my grandmother's 92nd birthday and celebrating that. And he was gray, ashened, puffy, full of fluid, not really looking well, and refused to go to the doctor because he couldn't afford me to take him to the emergency room, which that's where he needed to be seen. Couldn't afford it. Refused to go. I honored his wishes. Sound mind. Makes his own mind up. And he died 3 days later. People need to understand what it's like to be in someone else's shoes when you don't have the money to take care of your basic health care needs. He probably would have still been alive today. Maybe. But I guess that's it. I think I talked for 15 minutes. All right. Okay.
So, Aarti and Amy, what do you want to do?
I do the slides. Yeah.
We can make this work.
Perfect.
So, start performing.
Okay. I think it's called East Freedom Library and it has the date on that thing. So I'm gonna stand to it. That's okay. So I'm Amy Finnegan and
I'm Aarti Bahtt.
And we're part of a group called the Social Medicine Consortium. We're a group of health professionals and sociologists and educators that are interested in addressing the social and structural determinants of health. And we're filling in for our colleague, Mike Westerhouse, who was originally asked to be on this panel, but he has his own medical health care issue tonight, so we're here to step in. And we're going to talk about our work in that with the Social Medicine Consortium. And I think, I was trying to think about what are the connections with the labor movement, because I don't think that's the framing that we've often used in our work. And I understand the labor movement as an entity that's trying to build power to challenge the status quo. And that's essentially what we're trying to do as well. We're trying to build power to change the status quo, to change inequities that result in bad health or poor health outcomes. And also trying to build power to change what it means to practice health, to be a healthcare provider, a physician, a nurse, someone who's interested in health here in Minnesota and beyond. So we're going to start, I think Aarti was going to share something. That's also okay.
So first of all, I just wanted to thank you for allowing me to share this space with you. And I know I'm kind of pinch hitting for Dr. Westerhouse. So, instead of talking about things I don't know anything about, I'm going to just tell you a little bit of a story about what brought me to understand that my role as a physician goes beyond the walls of the clinic. So my life has always kind of been about conflicting identities and asking why and being curious. And as a first generation Indian, Kenyan, American living in a very small white Wisconsin town and going to Catholic school, I couldn't really ignore that conflicting identity. My parents, kind of knowing that we were in many ways outsiders, but also trying to survive in this community that we lived in, encouraged me to be curious and to question a lot. And I grew up with privilege and safety to be able to explore those questions freely and without fear. But I'll never forget a time when I actually, this very critical time when I figured out that some people don't have that kind of safety. And I was a young child, and my family and I were on a trip in San Francisco, and we were walking over the Golden Gate Bridge, and there was a homeless woman on the bridge. And I grew up in a very small town. I had not really experienced homelessness up until this point. And it was an elderly woman, and I think she was elderly. In retrospect, she could have been young, but her face looked sort of like weathered, and her eyes were heavy and fierce. And there were kind of the signs of a person who probably experienced amazing and really heartbreaking things in her life. So being like the good Catholic school girl that I sort of was, I gave her my allowance, and I felt like I was doing something important. But the question still remained, why did she not have a home? And then I had so many experiences since then, but sort of flash forward to 2 months ago when I was sitting at the Community University Healthcare Center in Minneapolis, staring out the window at my computer. We spend a lot of time on our computers these days. It's one of the problems with healthcare. I think someone had mentioned about how we don't have that time to just be with our patients, and Lisa, you mentioned that. And I saw like a homeless encampment across the street. I mean, it was growing and growing and growing in front of me like every single day. And I mean, there were like hundreds of people camped out in you all know about it. And those people are somebody's child, somebody's mother, somebody's sister, somebody's father, somebody's brother, sleeping in the freezing cold, huddled around the bonfire. And these human beings are also my patients that I see every day in clinic. And there was one particular Native American woman that I was seeing this day, and she said that she was with me for blood pressure follow-up. That's why she came to see me. And she told me, I'm not able to take my medicines because I lost them, and sometimes people steal them. And she said she frequently fears for her safety. In order for her to be healthy, yes, she needs good blood pressure, she needs health insurance, she needs these things, but in many ways too, health transcends those clinical walls. Homelessness is not just an individual person's problem, and that's what I've realized through the course of my life and my work. Many of us go into medicine to help people attain good health, but treating someone's blood pressure when they don't have basic safety, they can't meet their basic needs, is akin to throwing my allowance into a cup and hoping for a good outcome, right? Mm-hmm. It may help, but it isn't the whole story. Lilla Watson, an Indigenous Australian activist, she says, if you come here to help me, you're wasting your time, but if you come here because your liberation is bound up in mind, then let's work together. And this realization has moved me to think of myself as a physician as well as a social justice worker. It has led me to actively engage with organizations like the Social Medicine Consortium and help to start a Twin Cities chapter of the Global Campaign Against Racism to address the intersection of homelessness, racism, and health. Through this campaign, I've learned about organizing and the importance of organizing and how we need to build power in that way. And that's really all I have to share, is just that I'm inspired by all of you, and I see myself as so much more than just a clinician.
Would you say a little bit about what you have to do with the computer in healthcare?
Yeah, well, I mean, in order for clinics, and especially I work at a community health center that gets a lot of funding from various sources, but in order to get reimbursed a lot of the time, there's just tons of documentation we have to do. We spend a lot of time coding and clicking. We have 20. We're scheduled to have 20 minutes with each patient, and many of my patients have very complex medical issues and are dealing with issues like homelessness. They're dealing with issues like lapses in their insurance on and off. They're dealing with mental health crises, and 20 minutes just is not enough to deal with that. And so, yeah. And then we have to sit and chart and document. And so most of that work I take home and do after my kid goes to bed. So it's not ideal. It's not ideal. But anyway, I'm tag teaming with Amy because that's sort of just my story about where I'm at now in this journey and the work that I'm doing and the Social Medicine Consortium and the Campaign Against Racism. And that's kind of what we
Yeah, so this is a picture of we came together as a consortium in 2015, and this is our last gathering, which was in Navajo Nation in April of last year. And it's we're a group of health professionals. You can go to the next couple slides. I know this one, we'll go too forward here because this is what Mike was going to do. We're not doing that. Going forward. Keep going off of this slide. You were going to hear about Uganda, but so a lot of us were, you can go back one. A lot of us were kind of brought into this field through our interest in global health. We are followers, a lot of us, of Paul Farmer and Joya Mukherjee and people that were come together in this organization called Partners in Health that have really sort of integrated health and social justice, liberation theology, this idea of the preferential option for the poor, and trying to live that out in values around healthcare. And so we're just a lot of folks who are dissatisfied with the healthcare system, but also dissatisfied with the ways that health professionals are educated. I'm a sociologist, but my partner is Mike Westerhouse and Aarti, and a lot of friends, Aarti Bahtt and others who've gone through medical school curriculum, and a lot of people go in with this idea, I want to be a healer, and what they end up learning is a lot of biomedicine, a lot of what happens, inside the body. And then what we know from research is that what's happening in society actually has much bigger determinants on the health outcomes, right? And so part of what we've tried to do is to infuse some of that education into the health professional setting, into medical school originally, and then beyond. And so some of us developed this course in Uganda that did just that. And we were also trying to undo a lot of paternalism that happens in global health, where outsiders, largely white, Western, global North folks go to global South settings and kind of live out this savior complex that is pretty strong, and tried to undo some of that dynamic by creating classrooms where we had people from the global North and people from the global South working like as peers, learning together. And made some really important relationships and came together with some colleagues that were doing the same thing in Haiti. We were gathering in Chicago in 2015. We're dissatisfied. We're like, let's do something. Let's come together. Let's build power. And so the Social Medicine Consortium is born. Go to the next slide. We had a conference here in April of 2016 at the U, and had a lot of folks coming together. We're trying to figure out who we are. We go to the next slide. This is our vision and our mission and our principles. We're rooted in the belief that inequity kills, and that together we can achieve health equity by constructing systems that demand justice, recognize our global interconnectedness, and support the next generation of health professionals. So I think nurses have always been much further along than doctors on this field, and recognizing that inequity kills, recognizing that we need each other, that we're interdependent. But this has been, I think it's been groundbreaking for the medical profession, and part of what we're trying to do is bring in, so we can all work together. It's not just medical folks, it's sociologists, it's nurses, it's public health professionals as well. Go to the next slide. When we gathered in Chicago in 2017, we connected with Dr. Tamara Jones, who is, she's fabulous. She's totally fabulous.
We have to bring her back.
She's a physician, and she was the president of the American Public Health Association. She works at Morehouse School of Medicine in Atlanta. And she has really launched us into this thinking about the importance of understanding how racism operates in health and in healthcare. She came and worked with us and sort of challenged us to put out together this campaign against racism. So she said, you're teaching all these young people and old people, people of all different generations, to think about racism and how that has is such an important force in understanding health outcomes. But we have to go beyond just consciousness. We can't just go away from these classes being woke, that we understand, that health is beyond biology. We need to go beyond that. We need to actually practice that. And so she encouraged us to actually launch this campaign which is called the Campaign Against Racism. Go to the next slide. And then at the top there it says the Gardner's Tale. If you wanna, she's got a great TED Talk where she sort of talks about racism in healthcare in a really powerful, articulate, concise way that is, I think people can really grab onto. And it's called the Gardner's Tale.
Uses like an allegory to talk about it.
yeah, she has a lot of metaphors that are really, really beautiful. So when we were together in Navajo last year, we launched the Campaign Against Racism with, my stats are, we are 250 members, 23 chapters, and we have 12 of them in the United States. And so we have a chapter here in Minnesota that Aarti and Mike and I are part of, and we are trying a chapter of the Campaign Against Racism. And our chapter is working at the intersection of housing, racism, and health. So we are largely health professionals or health professional educators that are recognizing how housing is a structural determinant of health. Like if our patients, if our community members don't have quality, affordable housing as a foundation, it's going to equal poor health. And so we are trying to expand what it means to be someone who cares about health. Like Aarti was saying, she was educated in a particular way to be a healer in the clinic, but she's recognizing that if she's going to do that work, she needs to be able to engage and connect and interact with folks that are working on housing, because ultimately her patients are going to need that to do well and to be healthy people. We all need that. So you can go to the next slide. I don't know if you want to fill in any of this.
You're doing a great job.
This is our grand strategy. Our goal is to dismantle structural racism and its effects on health around the world, because racism kills, by supporting local actions, efforts, and networks which aim to improve the health and lives of those most affected by racism. So for those of you done organizing, you know that like coming up with a statement with 250 people is a lot of work, so we're pretty proud of this. You can go to the next slide. This is our organizing statement. We've come together and done some community organizing training, a lot based on the work of Marshall Gantz, and that is sort of, we're learning to tell our stories of self, which is partly what Aarti was sharing. We are learning strategy and tactics and all of that. So I think we have one more, which is just our Minnesota chapter. What we're trying to do, particularly focusing on health. On housing here in Minnesota. And I think the last thing I want to put, there's one more slide I'll put up there, which is, this is that we gathered last fall at the Highlander Center, which I know is maybe important to some of you in the foothills of Tennessee, Miles Horton. It's a very sort of strategic space for labor organizing in our country, and we were really grateful to have that space and come together with representatives from those different chapters across the world. So part of what is really interesting in this campaign against racism is that we have folks in the US who sort of understand racism in a particular way, but then we have folks in Zimbabwe and in Haiti and in Mexico and in Uganda and Palestine who are also seeing racism, but seeing it appear in different ways. And so one of the challenges for us has been, how do we talk about it, and how do we see it differently and feel it differently, and what are the words that we can use? I think we've come around really recognizing that white supremacy is something that we've all felt in different ways, but it's been something we've been navigating, how to do that thoughtfully so we're not leading too much from our American perspective. And then the last slide I think I have is just something we've been thinking about is like this idea of when we're putting out the tactics and the actions that we want to take. We're thinking about like how much time people have to put into this work, and then also the threshold for discomfort that people have who are interested in engaging this. And so we're trying to push the discomfort level of our healthcare professionals in seeing their role being much beyond the clinic. And then also, obviously, time is always, how much time people are willing to put into this work is always a tension. I mean, as Aarti said, a lot of us do our work and then go home and put our kids to bed and then start the second shift of work. And so asking people to put additional work time into organizing is a challenge that we're facing. If you're interested in this social medicine stuff, we do offer a class, that's my very last slide. In the fall, it's open to community members. Half of the class are students that are enrolled in the health professions through the University of Minnesota School of Public Health, but then the other half is anyone. So if any of you all are interested, and it's a couple $100. There's not a big like credit fee or anything. And we do, it's a classroom-less class, meaning we spend each week, it's Wednesday nights, we spend each each evening in a different space around the Twin Cities, talking about learning about health inequities and how people address them. We were lucky. That's how we got in touch with Peter. We were here last year and had a great walk down Kane Avenue. So,
Great.
thanks, y'all.
Thank you.
I'm the one non-health professional. Oh, you're not in here, okay.
Yeah, that's right.
Rose pretends to be a nurse. She just represents the nurses, and the nurses love it, which is wonderful. I'm John Marty, and wanted to talk, fill in a couple of gaps. I wanted to start by talking about with universal health care. I wanted to start by talking about two things specific to the labor movement for frames, one of which is Frances Perkins. When Peter asked about doing this, I thought we should mention her. She was the first female member of the United States Cabinet, first woman ever in presidential succession line. She was the longest serving Secretary of Labor, partly because the president she served longer than anybody else. Incredible in thousands of ways. She probably personally had more to do with saving lives of Jews from the Holocaust and World War II than any other American, because the Department of Labor handled immigration at that time, and she found ways to allow us to accept people that were very much hated by many, and so on. Anyway, when she was being asked by Franklin Roosevelt to serve as the first female cabinet member, she didn't say, "Oh, I'd love to." She said, "Well, here's my agenda." She said, here's the thing she's going to pursue if appointed: end to child labor, a minimum wage, 40-hour work week, unemployment insurance, old age insurance, and universal health insurance. She said if he didn't support these goals, no, she wouldn't take the job. So he said, well, he thought about it, and he said, I guess can we really do that? And she said, well, she wasn't sure, but she was sure going to give it her best. And frankly, I think she accomplished virtually all of them in some way, shape, or form, except the universal health insurance. And that's 80 plus years ago now. And some people say we're racing too fast when we talk about universal health. So some of us have a different sense of urgency than others. The second thing I wanted to say about labor movement and healthcare is the word solidarity. We're all in this together. What happens to you matters to me. Brothers and sisters in the labor movement know what that means. And one of the things that a lot of the labor movement things have not just helped members of organized labor, they've helped all of society. 40-hour work week, weekends, time off, everything that we've had, social change, they were, especially in terms of wage and hour and everything, they were started by the labor movement and often later on forced government to take that and make it apply to everyone. And healthcare is one of them that, as Rose's history showed, we have not gotten there yet. And we got this weird contraption of healthcare that largely in Minnesota, about 60% is employer paid for healthcare, or based healthcare, another 30% is the public programs, another 3% is the individual market, another 4 or 5 or 6 or 8 or 10% is the uninsured or really lousily insured folks. And bottom line is, of all of that, there's probably about 80% who don't have the health care they need. And some people now, some of people in my political party, the DFL, say, well, yeah, we like universal health care, but it's not politically feasible, so we'll fight for something else. They've actually got people calling Medicare for all, meaning this insurance-based system. And they say, well, they'll both cover everybody. And I think it'll cover everybody in the sense that the Affordable Care Act covered more people, but it didn't cover everyone. It never could cover everyone. When you have a system that you have to qualify for, there are going to be cracks in it and gaps between it, and people are going to fall in those cracks. And when you have 5 million Minnesotans, when you have 300 million Americans, a lot of people fall in the cracks. Maybe just temporarily, maybe permanently for a lot of people who are underinsured. Some people do it with rationing their meds, as Lisa's father did, with tragic consequences. Some people do it by not going into dental care. Some people do it every way they can. A lot of people do it by going into debt. And so the solidarity concept, where we're going to cover everybody, we're going to treat each other as if we're all important, is very important. Public education is part of that solidarity. Maybe you have to wait still till you're 4 or 5 years old, 5 years old to go to kindergarten in Minnesota. But when you turn 5, you don't have to qualify. There's no risk you're going to fail to get into kindergarten. If you fail the test, you still get in. If your parents don't have the right school insurance plan, you still get in. Why do we do it that way? Because we want everybody. We want the solidarity concept. We're a better society if everybody gets an education. And we would be, I think, a better society if every one of us had health care and you didn't have to worry about your employees not coming into work because they were too sick and they didn't have health care. You wouldn't have to worry about taking time off because there's nobody else to take care of your parent. You wouldn't have to worry about those things because everybody would be covered. And unfortunately, the way we've tried to reform health care in the last 60, 50 years, at least since Medicaid and Medicare, we know health care is expensive. It's extremely expensive. It's now 1/6 of our economy. 1 out of every $6 is health care. And if something's that expensive, the solution is, well, let's buy less of it. And so we've been trying to do it. We put barriers up in Rose, had some slides talking about that. And we've done a pretty good job, as she said. We make it harder for people to get health care, which is not what solidarity is all about. And it doesn't work economically either, as we're spending twice what almost everybody else in the world spends per capita. There are about 10 or 12 exceptions that spend more than half, but not that much more than half of what we do. And so if we want to start looking at a non-scarcity model, what do? Well, Rose put up on one of the slides some principles that we have for what a good healthcare system should involve. Certainly it's healthcare for everyone with no exceptions. Not just because you moved here from some other country, not just because you can't afford it, not because you're unemployed, not because you're old or young, but everybody's covered. Covers all their medical needs. Your dental care is important as your fingers and your toes. And as Lisa talked about the hospital in Albert Lea, and by the way, Mayo did the same thing to Fairmont Hospital a couple of years earlier. Widely popular in the community to have their hospital disappear on them. They weren't doing it for the good of the community, they were doing it for their bottom line. So our 10 principles include one that the health plan has to ensure there are enough providers to meet the basic needs, which means you're not going to have a neurosurgery department in the town of 2,000 people, but you're going to have hospitals in communities like Fairmont and Albert Lea, because that's part of keeping people healthy. And maybe it doesn't fit somebody's corporate bottom line, but it does make the system work well. So instead of this scarcity model, what if we are to provide a healthcare system that meets everybody's needs? Doesn't mean nobody's going to die. We're all going to die. We're all going to get sick. We can't cure everything. But people will get the care they need, and we can focus on prevention, the public health matters, and we're going to get rid of a lot of the disparities. Not all of them. The social determinants of health, all those things still matter. But at least we'll get a lot of these things taken care of, and that's a really wonderful thing. But then people, of course, say, how are you going to pay for it? And my pitch to this thing is, first of all, every time, as I said earlier, every time we've tried to reform healthcare, we try to reform healthcare by saving money. How are we going to save money? Which is why we got to cut back on things. And I think it was Lisa's presentation talked about the demographic thing where we're aging and we're getting aging and more, and a lot of us are aging at the wrong time. But the bottom line is the demographics don't look good and things are getting worse. And if we're going to pinch down and try and cut back expenses at the time there's more need out there, we're going to have a problem. So what if we take the opposite approach? We're going to, instead of trying to design healthcare systems to save money, let's design one to keep people healthy and get them care they need when they do. Well, I would make the case, and I think it's a pretty strong economic evidence of it, that you try and design a healthcare system that works as a healthcare system, it's actually cheaper than what we're doing now. Cheaper. We can't prove it yet. We're trying to get an economic analysis of the Minnesota Health Plan this year. We're asking for funding for that because I think comparing what we're doing now to what we're doing under a new system would make some sense. But we try and provide health care to everybody because that's what solidarity is about. That's what we do to take care of each other. That avoids all those things, the tragic stories every one of us knows. One of the favorite people at the Capitol, one of the newsworthiest people at the Capitol these days is Nicole Holt Smith, who's got a 26-year-old son, Richfield. He died 2 years ago, May of 2017, because he turned 26. He lost his parents' insurance coverage. He had a job. He was saving up to find the right health plan for him. He was saving up to buy some insulin because he was diabetic. It was $1,400 bucks. I think she said he had $900 bucks in his savings, in his checking account the day he died. He was saving up for it and he didn't quite make it. And that made the news, but it doesn't make the news. Most of the time somebody dies from a lack of insulin. Matter of fact, his didn't make the news when he died. He died in May of 2017. It made the newspaper, the Star Tribune, in May of 2018. Why? Because his mom decided she was going to fight this thing because she was so angry about it. So it happens far too often. It takes care of all those if we invest in taking care of people up front, which I would say is exactly what solidarity and the labor movement's all about, and why we ought to be doing this, and why we ought to be doing it now. And unlike, I saw Rose's slides last night or whatever you sent them around. I love the LBJ and the Superman costume. I've never quite thought of him. I mean, he did super things, but I never quite saw him with the tights and everything. But, for those of us old enough to remember, I do remember he pulled up his shirt to show us his scar after but the change from 1965 and Medicaid and Medicare till now is back then the medical industry. I think one of your slides showed that they were your postcard. They showed how strongly opposed they were to socialized medicine. And now 2/3 of Minnesota doctors say they think the best way to deliver health care is with a universal single-payer system. Nurses are wildly enthusiastically on board. Healthcare providers think we ought to take care of their patients, and they think they advocate, as one of you said, not just in the clinic, but advocate for them in the good of society. And so I'd say that's why we have to make this happen. And when people, I've been in the legislature for 30 plus years now, and when people ask about that, I keep saying, well, I'm not going to leave willingly till we pass this Minnesota health plan. And I do want to leave at some point, so I hope we pass it soon.
Can I say one thing? I just wanted to let you all know, you talk about medical debt, right? And that, a great deal of medical debt, well, a great deal of people that file for bankruptcy in this country, it's due to medical debt. And of them, most of them had health insurance, even though they still went bankrupt. I like to give a plug to the nurses because this is who they are and their commitment to this issue. For the last 2 years, the Minnesota Nurses Association has purchased in 2017, $2.5 million, and last year over $3 million of debt, and we have relieved families. Last year, 3,000 families in Minnesota, Wisconsin, and Iowa of their medical debt. We bought it and tore it up so that they can get the care they need again, because that's what we're going to do until we don't have such a thing as medical debt, because we are also the only country in the industrialized world where people can actually go bankrupt just because they actually got sick. And I would just also just say that, the nurses are looking at everything through the lens of health. And health is the issue of intersectionality in the larger justice movement, because, as we just heard, racism drives health outcomes. Poverty drives health outcomes. Environmental impacts drive health outcomes. Housing drives health outcomes. Immigration status drives health outcomes. All of those justice movements can come together around the issue that we're human beings and health matters. So, I just thought of that.
Well, I knew that this was going to be a substantial presentation tonight. I'm only disappointed there weren't more people here, but I'm very, very glad for the information and perspective that's been shared. So if you have questions or comments, please.
I've got a comment. Well, a couple of comments. Is it Lisa? Okay. I'm wondering if in greater Minnesota, how the pinch of people who have geriatric parents needing nursing home care, and they're having their kids coming back from college and moving in with them because they can't get a job. So now they're helping their kids handle their school loan debt and trying to keep the family together, and then they're still needing to take care of mom and dad too. And I'm just wondering if that is starting to become a bigger and bigger issue in greater Minnesota.
Most of it is some, it just depends on which part of the region that we're talking about. If we're talking about Southwest or West Central or the Iron Range, it just depends on the actual demographic area that we're talking about.
Okay.
But I would say that, a lot of the greater Minnesotans, the ones that are 65 and older, most of them are still, some of them are still working. Like, nobody can retire.
Yeah.
And what is true up in greater Minnesota is that they rely more on their Social Security than here in the urban areas. And the families are leaving, like their children, they're leaving so they can get more good paying jobs. They're going to more urban areas than staying out into the smaller communities of 900, 2,000, 3,000. So I know what you mean. I got 3 kids, and if anybody comes home again, I'm not going to be happy. Because they tend to stick around a while, But I don't need them to care for me yet. But.
And in the 1970s, here in the metro area, there used to be like 21 hospitals, and one by one they started getting bought up and they started forming these large conglomerates. And what I found interesting, because I've been in hospitals since the 70s, is that as they have changed.
I just want to make sure they didn't think you were literally in the hospital,
No,
like as a
no.
patient. He's a nurse.
But as the Fairview system grew and as the Alina system grew, it's interesting to take a look at that transition and note that every time they would buy up another hospital, there would be a name change. And eventually it got around to, it was the Fairview Healthcare System. Their last purchase of the University Hospital, when they switched their name, they dropped care out altogether. And each of these systems has dropped the word care. And I think that was the indicator. We are no longer a healthcare delivery system. We are the health business now. And that's helped get us into the mess that we're in today.
I appreciate what you said. I do want to say one other thing, if I could. If we need more community-based services in greater Minnesota, we need more home care services and providers out there. Greater Minnesotans want to stay in their home, but they want the security that their nursing homes will be there if they need a bed someday. But what they need for housing, you're talking about housing, is they need someone that, there's programs that they come in and they renovate, they fix. They need someone to keep the upkeep on their homes, build ramps, make things accessible in their homes in order to stay in their homes. So, I'm sorry.
Go ahead.
Just, I want to make a comment, especially for the person speaking about the large senior population coming along. Actually, I was an HR nurse recruiter in a nursing home and St. John's Hospital, so I understand all that and the quick turnovers and the work. But speaking from a grassroots organizing with seniors, there's a problem here because I belong to some youth-oriented, like the DSA and Take Action and some other groups, and we don't have much trouble convincing those people, those young people, that we need Medicare for all. But we're ignoring the seniors, and the seniors that there's something between myself and the community clinics where we should be getting to those people, because you know who I spend my time with? People who can drive, people who are healthy, people who eat, they all live on their own. They have no idea that there's trouble out there, honest. They read it in the papers, but they're not seeing it like there's a problem. We're not communicating. SEIU should be speaking to the senior groups, because we vote, 1 in 5 or whatever it is.
Go ahead, please.
Senator Marty, how can we talk to our representatives who are for the insurance companies? I mean,
Right. A lot of them are concerned, they're very big concerns about people losing jobs, and we make good money doing this and so on. And my pitch, the biggest problem, there's one political party that doesn't support any of this because insurance companies, one of their goals is to make sure we strengthen the insurance markets. My party is much more, we want to do this, but we don't want to hurt anybody, so we want to be cautious. And my fear is, the biggest way they say that is, we can't get there. It's not politically realistic. It's the only way it works. It's not politically realistic, so we'll pick something that doesn't work instead. And my pitch is, why don't we, I think there's a new crop of people in Washington, D.C. in the House of Representatives, new crop of freshmen in the Minnesota House of Representatives, the first class that came up after Donald Trump. And I think they were people who were politically active like people in this room were, but they sort of, after Trump got elected, they notched up their involvement 6 or 7 steps. They ran for office. And I think they're kind of what we need a lot more of in the legislature, not necessarily new or first-termers. What we need is people who think like they do, and that is that they weren't there to get reelected, they were there to do something. And for those who say, it's not realistic, we can't really get there, then my pitch is, you've just said something, it's a self-fulfilling prophecy. You tell me you can't get there, it means you're not going to work on it, you're going to make sure we don't get there. Then I just sort of think we should be asking, could you politely do me a favor, could you step off to the side and let somebody else take the question? We'll make it happen. I think that's
I like that
Well, to hammer home the point about the social determinants of health and their impact on our overall healthcare system, my last job was, I spent 35 years in the acute care system, University of Minnesota Hospital, Abbott, that's where we really know how to spend money. And then I spent a couple years at the health department, and Ed Ellinger's slide, which I use when I speak to every group, shows the social determinants of health, and there's a 10% slice called clinical care, and the $3.5 trillion that we spend in this country on healthcare, 10,000 some per person, 30% of which is wasted on the administrative burden of our multi-payer system. I want to get all this in there, and is actually about our clinical care system, our acute care and our long-term care system. The whole rest of the pie is about what is full of policy implications for other pieces of what really should be our healthcare system and public health, which are housing, nutrition, education, income, et cetera. Some of it is personal habits. Yes, we shouldn't drink too much Chardonnay and smoke too much, but, and then if you want to really get a great primer on, I think that Senator Marty has done an amazing job of talking about health policy and what a change in our payment system could do to help free up resources for our public health system, our schools, our home care needs. This is an amazing book, and I pitch it every place I go. This is what we're looking at in Minnesota. This is what we could do if we could get enough people to push up. It really isn't right now going to help for you to go to talk to your legislators, because we need people who will talk to each other, their neighbors, organize and get out and say, we need to fix this incredibly wasteful, inefficient system. And it's going to take like thousands and thousands of us pushing up, telling our legislators, and then holding them accountable when we get them there.
I just want to add that what we're dealing with here is actually, this is about a shift in the culture of who we are as a nation. It is the bigger question here that is really is about what this debate is about is, does government have a role in the lives of its citizens? You know, and I would argue, and I think the nurses obviously would as well, yes, they do sometimes have a role in the lives of their citizens. Because we've been hearing for 40, 50 years that government is bad, government's the problem, not the solution. Taxes, you know, are a waste of our money. Taxes are an investment in our society. They're an investment as us, as a people in our community. When they say, well, yeah, over in Europe, oh my God, they're taxed like crazy. They get stuff for it.
Yeah.
They buy stuff with those taxes, and they buy social determinants, right? Because you don't stress out about student debt. You get to go to college for free. You don't have to freak out about the fact that by law you get paid vacations. You get family leave. You get you get help when you have a baby at your house. You don't have to. You go into a hospital. You don't have to worry about a bill. When I was in Canada, we toured a hospital, and I said, "Where's the billing department?" And they were like, "You see, like Mary over there? Yeah, that's the billing department." They don't know what that even is. They're like, "We don't want you Americans to get hurt up here, because then we got to figure out how to invoice somebody for health care, because it's so foreign to them to even think that way, right?" Social determinants of health can be taken care of if we decide to prioritize in society those things beyond even just the obvious things of that clinical work that Ann was talking about in health. You know, Elizabeth Rosenthal, Dr. Rosenthal wrote a great book called The American Sickness, and she basically says we have now made money the metric of good medicine in this country, and that's a huge issue, and it goes to what Lisa was talking about. We do not prioritize and pay for people who care for one another. That's not a sexy type, that's not like Wall Street, right? Trading money and making a lot, you know, we're taking care of one another. Ooh, that's kind of icky. That's bodily fluids, and that's this, and that's that. We don't prioritize that type of work, and that is the core of the type of work we should prioritize as human beings, right?
Well, I mean, I loved it that John brought in solidarity as
Yeah,
a
no
way to
kidding.
look at this.
Exactly.
And that's just such a useful framework for what everything that we're trying to do.
And just one more thing, I'm sorry,
Yeah,
I don't
no.
mean to take, but you know, the other thing that is unique about the nurses is they use collective bargaining as a way to actually advocate for patient care.
Right.
So nurses, of course, they're professionals and they want to make a decent living and take care of their families and all that stuff, of course. But that is not generally their major priority at the bargaining table. They're going and they're fighting for safe staffing to make sure patients have the care they need based on the acuity of the patients, right? They're fighting about workplace violence. Hospitals are one of the most violent places to work in our society right now, right? Those are things that they're taking on because they figured out that collective voice is how they have to take on corporate healthcare in this country. And I tell you, one more success story for the nurses. 2.5 weeks ago, we organized 350 nurses at St. Alexis CHI in Bismarck, North Dakota. And that was because those nurses are trying to fight for their patients, and their community hospital got bought out by a big corporate West Coast, company that is now completely destroying what that community has known as healthcare. And those nurses want to fight, and they know they got to fight with that collective voice. Sarah.
So, I know a lot of people here know me. I've been a nurse for 25 years, but I also grew up in Canada. So I've been, I came here like every immigrant for the education. My parents wanted us, I started off, I'm 60 years old, I started off in a one-room school. Not too many people can say that. And, it's been so fascinating for me. I mean, I think immigrants really pay attention, right? Because whoa, what's going on here? And, back in the, I lived out in San Francisco and been on both coasts, Midwest, and back, and my whole family's major international business. So I'm like the misfit, right? I'm like thinking, really? And labor, rah, and so, we go back to the 70s, just post Medicare and Medicaid, and we already knew then that the cost of healthcare related to GDP in this country was called GNP at that point, right? Gross national versus gross domestic, and was too high. So really, the cost of healthcare in this country is probably the single biggest factor why we can't do business in this country. You know, and what's fascinating to me, I mean, I read the beginning of your book, Senator Marty, and it's like, you know, if politicians had been involved in racism, we would have gotten a 40-hour, you know, slavery, we would have gotten a 40-hour work week and been so busy congratulating ourselves. It's like, you know, the political will, you know, the tone deafness of, you know, not people like yourself, obviously, but and there's fantastic politicians out there anymore, but I mean, everyone's, you know, when I saw, you know, I was part of Aaron's campaign, like the nurses were, and, you know, everybody, the progressives, the labor, the social justice, we're all together on one issue. You know, healthcare as being intersectional with racism and sexism, you know, as tearing this country apart. And my biggest concern is it is playing so into the populist playbook. I mean, you know, you know, when Trump came in for the first time, oh, ACA is Obamacare for the people that are getting ready to lose their Medicaid? Like, that's the disconnect. That's the single sentence that tells you, you know, what's going on, you know, this rural metro divide. I mean, the single biggest thing when I did a ton of cold calling was people in rural areas are pissed off at the people in the metro. And I'm like, can I just share with you? We're all for the rural. We don't have an agenda against you. I said there's something called politics, there's something called corporations, there's something called people who want to get ahead in life and come to the colleges in the metro and then stay for the better paying jobs. That's the end of the short equation. It's not that we have anything against you, you know, and so people are all mixed up by these mythologies that, you know, the Republicans or, you know, like I'll tell you a fantastic book is Noam Chomsky's Profits Over People. You know, speaking to that neoliberal agenda, which the corporations, they are so on message. And we're all these little 1,000 points of light, but there's no MLK out there, there's no, you know, Susan B. Anthony, there's nobody out there that's like, we think the politicians are gonna do it for us. They're not. When the people take to the streets and demand something different and start voting people out of office, then the politicians will take notice. But this is how it's gotten skewed. And there was a guy here last month that talked about 10 strikes and talked about when big money, you know, the opposite of Citizens United, when they elect somebody, they're like, hey, Marty, here's the top 3. You deliver or you're done. You know, they're all over their candidates. You know, but we, the people who actually elect them, oh, I hope you do something, you know. You know, and it's like, it's so weak. You know, it's like, and I don't want this country to go into revolution, but it's like, I mean, it's like, everyone agrees there's a problem. There's no question that there's a problem. On the state level, on the national level, you know, and there's people who are really doing great work, but it's like, I just worry, you know, sort of this if not now, when, because, I mean, this is what, you know, the Democrats, you know, and I'm already hearing, you know, we got the progressive wing that's growing, and yet we still have that electable, you know, that electability. It's like, lead, you know, like drop it, and, you know, like we're all going down behind you know, it's not about electability. It's about, you know, I mean, I'm a Bernie fan because he actually outlines, and again, it's not political for me, it's about, you know, can you outline the issue and what you're going to do about it? You know, and it's amazing. I've talked to so many people, and you know what they worry about? The insurance company's going to be okay. This is how brainwashed. I'm not exaggerating. I can't tell you. I have talked to thousands of people, a lot of people.
Just tell them that there used to be blacksmiths. I mean, industry comes and goes in this country.
It's so personal. I mean, I can feel my heart rate going up. You know, so I'm done. I just am like, but that is like so amazing to me. Is they're worried about the insurance company? Like
So Senator Marty addresses that in his book.
I know.
If how we can replace those jobs.
Yes.
I get it.
Yes.
And I tell you.
That less than 1/3 of the job turnover per month in the state of Minnesota is the entire, you know, insurance industry.
Yes.
We can fix and the business activity resulting from freeing up the healthcare costs in business, we'd have an explosion of business activity and entrepreneurial activity if we took that
I
burden
want
out.
to make sure that we have time for everybody to speak, sister.
I just
You
wanted
got your
to.
troublemaker
I
sweatshirt.
just wanted to piggyback on what she said about speaking to the geriatric population. I
To
think
the elders.
I think as we go out to campaign and build some solidarity in this movement, I think we all need to come together and speak the same language. Because what I have observed is when I've gone to door knocking events, there's so many inroads as to the languaging that people are receiving. And I believe that we need to do more education on the public to create that knowledge base so that when we go to door knock and tell people about this movement, we're all speaking the same language. And then now as a practicing nurse, I happen to be working for Highlander Health Systems, and I am telling you, I have seen so much changes. Now I've been in this system now for close to 40 years. And as these years have progressed, I've seen nurses now moving from compassionate care to speedy care delivery. That is two different, it's like a dichotomy. So I think what the nurses are doing, those of us that have seen the wisdom of giving care and giving good care, we're trying to say we need to come back to the old ways of practicing nursing because that's where healing comes from. It's not from speedy delivery. And this is all driven by corporate ideas about, speed, outcome, business, money, and all that. So now as nurses, we're trying to create changes to all these observations.
Thank you. Alex?
Hey, how are y'all? Quick question for you all, Lisa and Ms. Rose.
Yeah.
Cool. So I hear a lot of healthcare talk from physicians all the way down to nursing assistants tonight. And one thing that I know, just having grown up here in the city of St. Paul, is we have a significant amount of PCA workers. But the PCA workers, which is, if there was a totem pole, would be at the bottom. And you take the PCA workers, and they're not even unionized. Why?
Some are, we represent them,
Okay.
17,000 of them, so we do represent them, and it's more of the family-based PCAs that we represent. You're correct, they don't have health insurance from their
So-
employer. You're correct, and quite frankly, we bargain with the state of Minnesota, so what do we need to fix? We need health care for all.
So,
We need universal health care, that's what we need, they wouldn't be left behind anymore.
So if there was health care for all, then PCA workers will then, by proxy, have health care.
Everybody,
But then
everybody,
they could
everybody.
have the ability to be unionized in its entirety?
Well, there's two separate issues.
That's two separate issues.
That's-
Two separate issues.
I think it's good to separate the two.
Yeah. No, what we're fighting for here has nothing to do with like being union or non-union. We want everybody to have health care regardless of whether they're union or not, right? Like, just like we fought against the child labor laws, we think that this is the right thing for everybody. And so PCAs, now our union is basically a union of RNs. So we don't have the PCAs. Our brothers and sisters over at SEIU Healthcare Minnesota have those folks, and we're actually doing some collaborative work right now together around offering scholarships to help folks that are PCAs, CNAs, LPNs that want to become RNs. We're giving, because a lot of times money is the issue, and it's a lot of people of color that have barriers because of finances, and so we're specifically targeting to help folks that want to lift up and do the next level and be RNs. So everybody would have the health care, everyone.
Because
Wouldn't be tied to
I
union.
know, for instance, my sister's a PCA worker.
Mm-hmm.
I have two cousins here, living here on the east side, both in which are supervisors of two completely different companies, providing PCA services to our elders and those with limited mobility of some sort here in the city of St. Paul. And when I asked them about access to unions, they have no idea what I'm talking about. So it's like, well, now we're talking accessibility, right? So if We have unions like SEIU that provides union protection to PCA workers. Where is the disconnect between SEIU and this large substantial amount of PCA workers that doesn't even know that you all exist?
So there are groups of PCA workers in this state that we do not represent. And they are agency PCA workers that are not family-based.
So like Dungarvan, let's take Dungarvan for example. I mean, they have dozens of thousands of employees right here in the state of Minnesota, many of which are PCA workers, poverty, primarily people of color, that and they have no union
Get
representation.
them a contact.
I will get you a contact, you can give me your number.
Labor organizing
And,
is usually about someone from that,
Write it down.
you know, that company, that organization, whatever, reaches out and says, we have an interest in being union, right?
Okay.
Can you guys come talk to us, tell us how this would happen, what would
Yep.
this look like? Because in the labor movement right now, it's hard to find out like how to get in, how to infiltrate into particularly private companies that own these type of things. So if we got somebody that says, I've got a sister, I've got a brother, or whatever, a friend that works there, and they're not respected as workers, I'd like to see them like talk to a union, hook them up with some of it. If it's not the union, and see if you're giving me, I'm gonna be like, I know just who you should talk to. I'll always help hook people up with the right way, and they'll do the same thing.
It's not necessarily
right?
that they have a problem. For me, it's just more so taking preventative measures, right? To
Sure.
make
They'll
sure
have
that
better
we have
benefits
systems
if they
in
have a
place.
union.
Yes, they have a voice
A
in their
voice.
workplace
Right.
for their patients too.
My question kind of goes up, here is our nursing home worker.
Yeah.
What percentage of nursing home workers are unionized? It's kind of similar to your question.
Not many.
Not many.
Not many,
Nursing
and
assistants, it's the same, it's kind of similar.
Yeah.
like I said, we have 30 facilities that are nursing homes that we represent in greater Minnesota as well as the metro area. And there's 300 and, well, what's the last count? 342 maybe nursing homes in the state. And AFSCME represents some of them. UFCW represents some of them.
Steelworkers.
The steel workers represent a whole bunch up in the Iron Range. And am I forgetting anything else?
I mean, we have a few, but not many, just where we're like wall to wall,
Okay,
type of stuff.
okay.
So like my overarching objective. So for those that don't know, I'm running for city council here in this community here, and so my overarching goal when it comes to community and unions is helping to close that gap,
Yep.
right?
Sure.
Because we have many unions right here in our backyard that we know have the ability to not only train individuals, employ individuals, but most importantly, protect their workers, right?
That's right.
And so we want to make sure that we can make sure that those services and resources are readily available to the communities in which they're actually located in, right? And so, I mean, we're not talking about something super far-fetched, right?
So some of our challenges will be things like, let's say it's a facility that is, I don't know, maybe privately owned in some way, and there's, 15, 20 people that work there, right? It is really hard, I'm just gonna be brutally honest with you, to go in and try to figure out how to negotiate organize and negotiate a contract for 10 or 15 or whatever, workers. And so, because we're stretched.
Are there policies and ordinances that can be introduced at either the state level or the municipal level to make sure that regardless if it's a private or public entity that's overseeing these employees, that these individuals have
Urgently need
access?
stronger laws at the federal and state, and I'm not sure how municipal one's good, but I have a feeling there's some things you could do at the city level that would help with that. But our laws, labor laws, have been very weak and getting torn to shreds for years.
But for instance, the
But we're saying-
$15 an hour,
Yeah.
that would immediately raise the wages for all PCAs
Yeah.
in St. Paul, you know,
So
for
that's
all
where
every
the city
Friday.
council review had a huge role in that. Strengthening the labor laws to help them organize better.
Right.
That's our fault at the state level. And I mean, and every time there's an effort to strengthen labor organizing law, there are 20 attempts to weaken it, right to work and everything else. They keep coming with that over and over. The system is rigged against unions right now.
So what we're trying to do at SEIU Healthcare Minnesota, and which some of you may have heard about, is we're actually recruiting movement members, is what we're calling them. And Cure down in Rochester is affiliated with us, and they're dealing with the housing movement down there. We're starting another movement in another city up here in the metro, moving through Bloomington soon, and we are working within the next 3 years here to get nursing home workers, since we don't represent a whole bunch of them, but we represent quite a bit of them, to get them on board on legislation, on what we're passing, how to get involved. Because once you find that thing that people care about, are passionate about, that'll get up every day and fight like hell for, they're gonna join, and they wanna be educated, and they wanna know how to get involved, and that's what the whole movement member thing is about. And it's for everybody, not just a union member.
Right.
So.
Right.
So is SEIU dedicated to moving policy that allows PCA workers to be covered through the resources that they currently provide for their members?
All of us would
Well,
support this policy.
Yeah, I mean, yeah. I mean, I'm gonna give you your name, and you can sit down and talk to our home care director, who's also an executive vice president. He's my counterpart, as well as maybe the president would even invite you to come in and talk to our executive board if you're running over here.
Yeah, I
My
got an
hometown,
endorsement.
all right. Okay.
So let me just wrap this up. I want to just add, you know, so much of the conversation has been about the intersectional dynamics, and we are going to have a program here on April 10th on the housing gap. That is the gap that in the state of Minnesota, about 75% of white people own their homes, and about 25% of black people own their homes. And so that's central to the social determinants that these guys are talking about. It's central to the intersectionality of all these issues. Come and join us on April 10th, when a number of people who are working particularly on housing are going to be talking about the legacy and power of racism in housing here. And I also want to offer that I think that the sister in the great sweatshirt here, which I love, that you know, that if more education, more organizing is what you want to do, this is a space that you can use. Come and have workshops here, come and have gatherings here. You know, if you want a space where the people that you want to organize and educate will be comfortable coming, bring them here. And this space is available and will be available.
We need PBS to cover things here a lot more. They cover stuff as mushy so many times.
And so please, you know, can talk informally. We're going to break this up now. How about just a little bit of love for the presenters? Lisa was lying. She's never done this before.
I haven't. I've never done it.
And the M&A nurses in the room, we gotta hook up with these guys,
Yeah.
right? We gotta go reach out with these.
And hasn't that you've been talking to me for years about?